Hello again. The NHS has provided care to more than 600,000 patients in hospital with COVID from the beginning of the pandemic. The virtual ward is designed to act as a solution to relieve hospital beds by managing and monitoring patients from the comfort of their own home. Using remote technologies, patients will be able to access healthcare through means of mobile IT and report any issues to clinicians. December 2020, target was set to increase the number of virtual beds used by 5,000, and every integrated care system should have 50 virtual wards per 100,000 people by the end of this year. Virtual wards and digital care is our third panel of the day. So let me introduce you to our panellists. We have with us Ian Hogan, Chief Information Officer of Northern Care Alliance, James Reed, Chief Clinical Information Officer, Birmingham and Solihull NHS Mental Health NHS Foundation Trust, Catherine Dale, Programme Director, AHSN for South London, and Tim Cullinan, Deputy Director of NHS England. So please do keep using that Q&A feature that we have available to you at the bottom of the screen, so that when I get a chance, I can pass on some of your questions to our panelists. So very warm welcome to our four guests for our third and final panel of this morning. Catherine, I'd love to start off with you, if that's okay. Just giving us a sense of the purpose of the virtual wards and the problems that they're trying to solve for us.
Yeah, thanks ever so much. I think that what COVID showed us was the opportunity for connecting with people through technology when we can't have face-to-face connection with them. We've all kind of known that there's more potential for that in healthcare for many years, but COVID, one of the upsides of COVID, if I can put it that way, was that it forced us to have to explore that much more actively. And virtual wards were actually a core part of responding to mainly the second wave of COVID, when there was enormous pressure on hospital beds. And so people were really thinking about how can we ensure that we are looking after patients safely, but not taking up precious resources within hospitals where we can. So that has really prompted the thinking about the opportunities to provide care for people in a different way, but to make sure that there are those connections. I think sometimes the term virtual can feel quite frightening because it feels quite distant, when in fact, if we've got really excellent technology that is very reliable for the people in their own homes and for the clinicians to find out what's happening, it can actually bring better connection between people. I think that's what we are trying to capitalise on in the work to develop virtual wards more.
Oh, I sort of know what you mean there. And actual virtual to some people will probably feel nicer because it's in their own home. But I would imagine some people would be, as you say, perhaps sort of put off by the word virtual. Tim, Catherine's definitely right, isn't she? That, you know, virtual wards have been accelerated because of the pandemic, but they're not a totally new thing, are they? And I'm just wondering how technology adds to the delivery model, if you like.
Yeah, thank you. Yeah, I think one of the things we have to be really cognizant and aware of is people have been, talking about and implementing forms of virtual wards for a very long time. So this is not an entirely new thing by any means. I do think that there's been sort of fundamental changes in both perception and also some of the I don't say quality, but how the interfaces of the technology work with people as well. So there's been both a mindset in patients and also in how the tech works for people has made real demonstrable progress during the pandemic and prior to the pandemic. So I think that's been really helpful. I think the other bit in terms of the technology is, and for colleagues who were on the previous session where we saw the BBC film, there's a real patient opportunity to have additional input from patients and additional input to patients through the advent. Previously, I think there's been a feeling of the health professional has all the information, they have all the answers, they have all the knowledge, which undoubtedly, that's not untrue, but also the patient holds a lot of that too. And the more we can furnish them, and the technology can really support them to be a more sort of informed patient and have a more of a sort of peer conversation almost. So I think that's a real sort of benefit from the technology. And I guess the other bit, having worked in operational management roles in the NHS, there's something for me about how it can help prioritize workload. So we all know everyone is massively overstretched. But if I know, for example, that Catherine's monitoring and readings are really good today, but we know Helen's are off for her and her normal, it helps me as a clinician say, actually, I really want to prioritize going and talking to Helen, and maybe including face-to-face as well. It doesn't have to be, this is all purely technology replacing, but it does help in the sort of patient-centric and also health professional prioritization in what is a really challenging environment. So I think a range of opportunities in short, Helen.
Let's bring Ian into the conversation. Ian, naturally, there's going to be of delivering mobile monitoring and provision of care. What are the challenges and how are they being overcome, in your opinion?
Thanks, Helen.
Isn't it? Sorry, that's quite
the easy questions.
Come on, solve everything for us, Ian, in the next couple of minutes.
Easily done, easily done. I think there are a number of things that we need to be really mindful of. And there's a couple of elements which are key drivers in us being able to deliver against the requirements. I think one of the big things, and it's certainly a massive issue within the Greater Manchester region where I'm based, is around the digital exclusion piece and ensuring that we identify the capability to actually overcome that. I think it's really easy to just automatically assume that people are connected. We've got, I think it's about 20 to 25% of the population in GM live in digital inequality, where there's a lack of data and there's a whole lack of provision. So the use and the selection of the type of technology that we want to use and be able to deliver to our patients is really, really important. I think there's that element as well in relation to the usability and the user interface, and Tim sort of touched on that briefly before. Whatever we have and whatever we deploy has to have that reliant user interface. There's an element of if you look at the level of acuity that we want to look after, are we moving? Is it around early discharge? Are we focusing on admission avoidance? The patient cohorts will be very separate and very different, and the needs for them may well be different in relation to aspects of the technology and also the type of devices that we want to put out. So I think it's really clear, and from a digital perspective, it's really clear that we need to be really engaged with our clinical colleagues and understand what the model of care and how that's going to transform to support the patient in the home, to ensure that we get the level of care that's required, and how the technology and the devices actually intertwine to be able to do that. I don't think there's an easy answer. I think it's almost, I wouldn't say necessarily a case by case, patient by patient, but certainly I think there's a cohort by cohort view in relation to how we have that level of engagement and how we can ensure that we can deliver the type of technology and the accessibility to the technology to be able to support what it is that we need to deliver.
You're so right, Ian. I think there's no one size fits all, and I think that was a very good answer to what I feel a bit mean for giving you as a first question. James, I haven't forgotten about you there. You're Chief Clinical Information Officer at Birmingham and Solihull Mental Health Foundation Trust, and I just wanted you to talk us through, at the beginning, when I first started reading about you and your work, I was wondering how virtual wards might be able to help in the mental health arena. And actually, there have been a few indications to that on the other two panels this morning. So I will let you explain exactly how virtual wards can help.
Well, yes, I mean, obviously, as always, mental health has been leading the way here in that virtual wards as a concept, if you like, has existed since probably the 1990s, when we saw, for those of you with long memories will remember the wholesale closure of the psychiatric hospitals. And part of the point of that was to move care, even in crises and emergency, out of hospitals and into the community. So it's something we've been doing, as others said, for quite a long time. Although in those days, the height of technology was probably a telephone and not a lot else. So that's where we've started, and we've been on a journey with that ever since. I think what we've learned more recently, although in mental health we don't do so much of the specific sort of device-based vital signs monitoring and all the rest of it, but what we do as others have hinted at, is establish good communication. And I think what the pandemic allowed us to do, actually, or gave us permission really to start exploring all these different ways in which we can communicate. I think historically, it's always, the view has always been, well, you've got seeing the patient face to face is the best thing, and that was always accepted wisdom. But I think one thing we've learned is that isn't necessarily the case. It does depend on the patient, and it depends on the situation. There are, and I've had interesting accounts from some of my colleagues where they said that actually they had, say, a text message exchange with the patient, and that was the best conversation they'd ever had, because actually for some patients, sitting in a room face to face with is actually can be quite difficult, maybe even quite intimidating, and it's actually not easy. And this may say more about me than others, of course, but some of my patients would rather have a video call with me than see me face to face. And I think what that tells us, I suppose, is the importance of offering choice and offering tailored interventions based on the need. I mean, most of us would agree that in medicine, what you should be doing is offering the best thing for that particular patient. And I think that also applies to communication and using all these different, we have this whole toolbox available, which ranges from a face-to-face at one end, perhaps to a online chat or something at the other, or a video call in between. And we should be able to use all of those. And we certainly are. And our crises services, which are probably the closest thing to a ward, if you like, are making full use of all those different options. And that helps maintain patients at home and out of hospital when they need to. And I'm sure that it's leading to a better standard of care, because previously, I think staff perhaps might have wanted to do stuff, but didn't really feel empowered, if you like, to do so. So both staff and patients, I think, are much more empowered than they were.
Yeah, and I think when you're not well, a bit of empowerment helps, and it makes you feel more confident if you know somebody's got an eye on you. I think that's actually really important, and that can be as simple as a text, I would imagine.
Yeah.
Checking somebody's okay. Catherine, I was going to ask you about, how we know that patients and the public are supportive of this approach. But the other thing I wanted to weave into that was picking up on what Ian mentioned about the fact that in Manchester, 25% of patients are, face digital inequality. So I wanted you to try and weave that in as well, because it's really important, isn't it, that digital is inclusive, and that we're not leaving out and moving forward without a substantial portion of the population, often the population that are perhaps struggling financially, or finding perhaps that they don't have the smartphones, or they don't have the iPads, or the things that many of us are lucky enough to have.
Absolutely. There's sort of, as was mentioned, the kind of need to understand the form that digital inequality takes. So it can be, we kind of have previously thought about reluctance of people, and people kind of like not being used to technology, but it's not as simple as that. It's often financial. There's a report about kind of people having to make choices between paying for data versus paying for food. And as we know, the cost of living crisis is such at the moment that people are having to make such extreme choices. So yeah, we must be absolutely ensuring that we're not increasing health inequalities by delivering new models of care when we're not thinking about how those are reaching people. Because when these technologies and these approaches do reach people, then often when they're successfully this keeping in touch with people feeling properly connected and kind of being able to link in with the health services in a different way, that's actually very positively received by people. But we have to keep co-designing, co-developing these technologies, the actual tools themselves, pathways for them with the people that we are trying to impact on. We need to do more of that generally, but I think that's even more important when we're talking about moving care to be essentially located in people's homes. We've got going on for people in those places and ensure that the things that we as healthcare professionals, be we clinical or managerial, we sort of be happening, that those things really are. Because otherwise we're in danger of creating a sort of myth of a service, but not something that's actually reaching people and therefore creating the outcomes that we're trying to impact. But I do think it is a straightforward approach of involving people, of partnering with the people that we're particularly trying to reach, of having constant discussions with people about how this is working, what the impact is, how we can keep tweaking it, because these are things that are having ongoing development happening with them, and it's just involving people and those who we are particularly trying to target in that ongoing development and design.
I think as well, we've got to be careful that we can actually book an appointment and go and see a GP. I know from personal experience, it's very difficult to do that where I live. And it seems a shame because not everybody wants a phone consultation. And I think we've got to be careful that we don't lose sight of the value of the GP surgery. Tim, I know that you care, as I'm sure probably everybody does actually on this panel, about health inequality. And I just wondered if you wanted to follow on from what Catherine said there.
Yeah, no, thank you. Appreciate the opportunity. So yeah, it's something that's really, really important. I think it's one of those things that we often sort of reference. I don't want to say lip service because it's much more than that, but we often talk about it a lot. But I'm really keen on where are the opportunities to turn it into concrete, actual pieces of work that genuinely make a difference. And I think it's more than just that. I think it's a recognition and appreciation of what can be learned from these pieces of work that help get to these cohorts. I was at a session before, and they were really keen that people weren't referred to as hard to reach, but better to be referred to as seldom listened to, which I think was that sort of really struck a chord with me. And it was also to say that actually a lot of the work to get to be better listeners to this group can lead to a lot of innovation that helps in the services generally as a whole. So it can really help us think about how do we open up the access. One of the pieces of work I've been involved in previously, we talked about broadening the front door. And I know that people think, what about capacity issues? But how can we enable more people to be able to access services in a range of ways, which is helpful for them and does improve their care? I think it builds on what James was saying around, actually, for some cohorts, a quick text message exchange is much more convenient, much more preferable, and doesn't have to be, we don't have to assume that everyone needs that same option. So yeah, I think certainly in our work, we do something called the regional scaling program, where we look to sort of scale support at home, which Reedmon mentioned. And every year we're trying to turn our intention into concrete action. So we've asked people to complete details around what have you done so far to ensure we're not exacerbating the problem? What have you learned from that? And how are you applying that in your next phase of work? So we're really, really trying to drive it because I think it's so important. And like I say, I think for me, the really important bit is what's our concrete action.
Action is so important. There's so many in general life at the minute. There's so many sound bites around, whether you're talking about sustainability or whatever. Action is required, and that's something that's been lacking, and I think across the nation in lots of different areas. So that action is so important. While I've got you, Tim, I'm just wondering what difference the virtual wards make to patients and healthcare professionals, and whether you see any downsides that we have to look out for.
Yeah, I think like anything, it's about doing it in the right way and recognising that there are a range of key factors to success around getting really early patient involvement, really early clinical engagement, really early awareness of the local landscape. So there are a range of factors, but then there are some success factors within that. I'm just really I like to focus on some of the patient outcomes around it. I've had some really good conversations with patients who said, we really appreciated both the ability to be at home, because anyone who's tried to sleep in a hospital bed, and nothing against the thing, you are unlikely to get as good night's sleep as you are in your own bed. Something about having grandkids around, having your own food or your children. So I think that's a really positive bit. One other bit that I found positive from speaking to staff cohorts who have implemented remote monitoring is actually the way the model is set up, it does allow you to have a more individualized, more focused conversation with parents. So if you're on the ward, you know that you're getting pulled from pillar to post, you've got to go and see such and such, you've got to do this, oh, my beeper's going off, oh, you know, a range of things which mean I've got a lot of things happening. Whereas when they're supporting patients in the virtual, does enable an element of more direct face-to-face care. We've heard that from a couple of instances. So I think that's positive from a staff perspective. The last thing I'll mention is as part of a sort of portfolio career for people working in healthcare, I quite like the opportunity to do some of this more virtual interactive stuff rather than literally being on their feet all day on the ward as well. So there's a range of benefits, I think, to both patients and staff, but it needs to be applied locally. So what I don't want to say is it's one way of doing it perfect for everyone. It does need that local adaptation.
James, just thinking, is there a crossover between physical and mental health care?
Well, I mean, clearly, and to be honest, I mean, this is one of my little things. There's not really there's not a difference in physical and mental health care, really. I mean, healthcare is a thing. You know, you treat patients as individuals, and everyone has a mixture. You know, so, and in some respects, I think over the years, it's not been terribly helpful that we've kind of separated mental health services out. So there's clearly, I mean, yeah, there's some simple things. You know, you can say that a lot of physical health, if you like, conditions will have mental health type effects, you know, even down to and this is why there's a lot of work we do in general hospitals. But similarly, a lot of our patients who we treat primarily for things like schizophrenia and so on often have poor physical health. And there's a big debate actually at the moment about how we can improve that. Part of it is to do with closer working with primary care and other health services, certainly. And the whole concept of data sharing is an important part of that. You know, and for example, I mean, if a patient of mine happens to be admitted to a general hospital, it's very helpful to be able to see what's happening and they can see the medication we've prescribed, very simple things like that. Because again, sometimes the medication may have impact upon physical health that wouldn't otherwise be noticed. There's an awful lot of crossover. And I think in this new world, you know, where we're trying to work in a more integrated manner across the board, I'm hopeful that we'll see, you know, a closer integration of that, and that we won't get into the age-old traps of thinking that, you know, these mental and physical health care are two separate things. And in fact, it's just all about caring for the patient at the middle of it.
Yeah, and also mental health affects so many of us, doesn't it? That there's often, it goes sort of hand in hand, I'm sure, for so many people. Ian, excuse my ignorance, but are smartphones the go-to device at the minute? And what do you see as the evolution of connected devices and wearables in this kind of space?
I think in the short term we have to be looking at that smartphone base, because it's probably the most prevalent piece of technology that we've got across the population. And again, I suppose there's a link in relation to some of the technologies that are provided as to whether or not you provide, as part of whatever platform that you may use, a device that comes as part of that, which is your connected device into the relevant equipment. I think we've been, from a digital perspective, we've been talking about the Internet of Things for a long time, and connected devices, and broaden it from not just from a health perspective, but into also the care element. We've got smart fridges, for example, and even from a care perspective, so which you can connect up. Yeah, so even to the point of understanding if a door to a fridge is being opened, which may indicate that someone's up, got some milk, made a cup of tea, got a drink. It's broader than just, if you like, that direct physical health. And I think that's the area that we should be aspiring to be able to connect that and almost become a connected home, as opposed to connected health devices. If you think of an Apple Watch and the ability to do ECGs, the sign off and the configuration of everything, and the ability to sort of record metrics on any type of device that you may be connected to, whether it be your steps through your Apple phone or your Fitbit or any other type of smartwatch that's available on the market, to then the evolution into sort of the more connected and wearable type of device. So there's a lot of work going on at the moment, which is looking at, if you like, a smart vest. So it's a vest that you'd wear underneath your normal coat, and take six or 7 or 8 different measures and be able to remotely and automatically transmit them into a platform, into EPR. So you've got that active monitoring without the intervention of the patient, the client, the user, to be able to go, oh, I need to take some patient recorded observations, as opposed to not having to worry about it and it being relayed, whether it be on a set period. And I think that's the area of, evolution is into that space, because I think the more we can take it away, maybe from the ownership from the patient of, for example, at 10 o'clock I need to take my blood pressure, I needed to hook up my pulse oximeter, I need to weigh myself. There's an element of a weak transfer and white coat syndrome into the house in relation to, oh, I've got this time frame to be able to do it. Whereas if there's just that passive view of, well, actually, you don't need to do anything because you're already connected or you're already wearing a device that's going to automatically transmit on a pre-described period to be able to do it. But I think that's where the focus needs to be on the development piece. I think there's an element of also, there's a concern, I think, from a population perspective of we can't be caught in the perception of we are offloading our care responsibilities onto the patient to be able to go, well, you need to do A, B, C, D, and you need to do it at 1 o'clock, 3 o'clock, 5 o'clock. Certainly in the higher acuity space where there's a perception of, well, that's the type of thing I'd expect from my healthcare professional. So there's an education and communication piece to make sure that patients are fully aware and understanding of what that virtual care means. And also
slightly alarmed about the smart fridge. I hope it's not going to tell me I shouldn't have another glass of wine. But anyway, interesting what you say there about the Apple Watches and things like that, because I was doing an interview with an Alzheimer's research scientist the other day, and he was talking about big data, and he was talking about all the pattern. They're trying to spot Alzheimer's 20 years before the symptoms show, and that big data that many of us collect on our watches, whether that be, how much REM sleep we've had or our heart rate or our steps or whatever, is really useful for data crunching when they're looking for signs of things like that. I'm aware that I am kind of running out of time, so I'm going to go to the floor in a minute. But Catherine, I just wanted, while we're talking about technology, what do you think is the best technology to support virtual wards? And then I'm just going to have a quick flick through some questions and see if we can share those out in the last 5 minutes.
It looks like this is a really developing area, that there isn't a single technology that is the answer to everything, but partly because virtual wards are not one single thing. We are describing a number of different things. So it's an exciting area, but it's also one with lots of complex sides to it, understanding what things are going to mean for patients, for clinicians, making things very straightforward and making sure that they interconnect with other systems so that they are going to be successful and relate to the pathways that we're developing as well. All of those things are needing to be considered. But there's lots of development going on in terms of the technology and in terms of people learning about how the different technology works for the things that they're trying to set up.
Fantastic. Irina says, will this session be recorded and the link be shared? Yes, Irina, I'm sure if you talk to the team at Cognitive, you'll be able to look back on this. Carol says she agrees with Ian that a holistic view is needed when planning digital technology in the home. Emma asks, perhaps this is one for Tim, has there been a challenge in upskilling clinicians to work remotely with patients? Are these now considered core skills?
Thank you. So, yeah, there has been a piece of work actually around with Health and Education England around skills and competencies to support people with working on a virtual ward in a virtual ward space. So I think that is really important. One of the bits I think is really key actually is around how we have the workforce to enable the onboarding process to work really well. And that may or may not be clinical, but there's something for me really important about those initial conversations around how do I actually make this work? Someone says to me, download the app from the App Store. A lot of people might have no idea what that process even involves. So I think there's something really key there, because that also enables us to understand if someone's right for this type of care or pathway to approach as well, and what might be needed. So yes, there's some formal stuff on HEE, but yes, we need to have a recognition that onboarding is key to how they'll interact with the processes.
Okay, and just a quick one from Jane. To what degree is there patient involvement and co-production in developing the technologies? We have very intelligent and technologically capable young patients who could be a real asset. I don't know who anybody wants to comment on that, but whether there can be some patient involvement in developing the technologies we need now. Any quick thoughts?
Well, I think, the simple answer is yes, there can be, and there is. I think there's been a building recognition of the importance of patient involvement in the areas where they bring their expertise, and certainly that's something we've been trying to do in all aspects of our service development.
Brilliant. That It was a very nice short answer, James, because that's what brought me out exactly on time. I'm always racing against the clock there. It's been a fascinating panel discussion, as I knew it would, and I hope I'll see some of you on our future NHE conferences, because you've been smashing. So a massive thanks to our panelists, to Ian, to James, to Catherine and Tim for taking part and sharing their knowledge with us. And thank you to you for taking part. You're a very responsive audience today, which makes my job an absolute pleasure. Now, next up, we have our third keynote speaker, James Musk, the Director of the Public Sector at SONICWALL. James will be bringing us up to date with, and actually the bit that I was going to say is missing from my script. So I'm just going to rather unprofessionally hand you over to James, safe in the knowledge that he's going to inspire us for the next 15 minutes. Over to you, James.
Slides for me and move them forward. So yes, ransomware, the savage reign, building resilience in healthcare. It's a pertinent topic. You know, security, cybersecurity is an important topic across all sectors, but especially the 13, the NCSC, defined as critical network infrastructure, especially healthcare, where we're wholeheartedly focused. So if you can move forward a slide, please. Oh, that's building very slowly. So quick 1 minute overview of SONICWALL. We've been in the business 30 years, and over that 30 years, we've built up thousands of clients across over 200 countries. Our end-to-end portfolio is cybersecurity specific, so we're not distracted by other routes to market and go to market. This is wholeheartedly focused on cybersecurity. And during that 30 years, we've built up hundreds of terabytes of data. Our global threat intelligence footprint is critical to us. And off the back of that is our cybersecurity innovation. So this is where we've got over 300 innovative patents approved, including, most importantly, our real-time deep memory inspection, RTDMI, you can see on the right there. And I'll talk about that in a little bit more detail as to how that actually operates and what it gives our clients. If you could move forward a slide, please. And again, so the challenge we face. This is a slide I delivered at Cyber UK across the whole government piece. Ultimately, we have a big market. Our market's estimated at 250 to 300 million in the next 3 years, but the cyber crime market is 40 times bigger. It's the third biggest economy behind the US and China at 10 trillion, 5 trillion currently. So this is a war on revenue, and it's stacked against us. We need to do more with less. If you can move forward a slide. So on that note of doing more than less, our overarching go-to-market is to help reduce the cybersecurity business gap. So actual headcount, actual resources, actual budgets in healthcare are very tight. We've seen 3.4% announced as an additional investment through this year, but inflation in the UK is at 9%. So everyone's going into next year already behind the curve. And yet on the other side of it, the cost of conventional security, the complexity around what you're managing, and the security personnel and the skills required to deliver that are increasing. So this is a major gap we're trying to fill with automation and ease of management. If you could move forward a slide, please. So I wanted to take one example, and this is the HSE attack, ransomware attack in Ireland last year. These are estimated timelines. You know, I'm not privy to the personal information of the account, but publicly accessible. We are led to believe that an email was opened 2 days after it arrived in mid-March last year. That delivered the lethal blow of ransomware. But it's the onward journey that I want to talk about. So the antivirus software, the signature-based software, not zero-hour threat capabilities that we're going to talk about delivering. The antivirus software picked it up a couple of weeks later, so a major window of exposure for that ransomware to spread. It actually spread across over 90% of the company. So clear segregation wasn't delivered as it should be. Segregation and separating the network to stop widespread breaches is very important. But it took an external service provider until mid-May to highlight to HSE operational staff that there was actually an attack in situ. So that's an even bigger window of exposure, probably down to alert fatigue, loads of information coming at multiple people, and not enough clarity on making sense of where the priority should be. So it's this job of us here at SONICWALL to pass over actionable intelligence so that you know it's an important thing that needs to be looked at. That's the critical thing that can stop that issue of tooling. We've already seen in this timeline a lack of tooling, maybe a lack of operational processes, probably alert fatigue. And it took them until June of last year to actually get 70% of PCs and servers back up and running and de-encrypted. We've got technology that can do an automatic rollback at the endpoint on infection, even if it starts to take a foothold. So tooling is still very important. And then we see an announcement that in September, they still had 90% or 10% of their systems left to recover. And their CEO talks about over 100 million euros of cost. And we know the breaches themselves are actually, well, the cost of recovery is 24 times the actual breach or the actual ransomware. If you could move forward a slide, please. So what we do here is we have a normalized data from across our entire network, all our honeypots, over 1 million sensors globally, and we produce an annual threat report. In fact, we've got a biannual one coming out in the next few weeks, but this is taken from everything we saw last year. If you can move forward a slide, please. So at a high level, we've got over 1.1 million sensors globally. We now see the bottom figures actually out of date. We see over 30 million pieces of malware a day. So when we're doing our real-time detection capability in the cloud, whatever we see that's new, we then build a signature and pass it on to our clients. So for example, if you're a SONICWALL client and you let your support and your service subscriptions lack, even if you didn't have our extended security subscriptions, you would be 30 million pieces of malware behind per day that you weren't up to date. So it's critical to maintain this war on revenue and the fight against all of this malware. If you want to jump forward a slide, please. So at a high level, this is last year across the entire globe. You see on the far left, malware was down 4%, but actually domestically here in the UK, it was still up 48 or 49%. IoT continues to grow. These are much smaller figures, but obviously in healthcare, you've got a lot of IoT. You've got the threat of home networks. We have secure hardened Wi-Fi connectivity for home as a use case as well. But on the network, you've also got a lot of legacy kit. There's a big push for digital transformation, but there's legacy systems, applications, and IoT still in situ. So a definite threat for your industry sector. The paramount ones here on the right, 105% year-on-year growth of ransomware globally last year. On the right, encrypted threats. This isn't an attack methodology. This is any one of the attack methodologies being in encrypted traffic passing through your firewall. If you do not run DPI SSL, deep packet inspection for encrypted traffic, to which we saw 82% of our entire traffic last year was encrypted, then you're not able to open up that encrypted traffic, look and check for attacks types, and then recompile. So that's a critical one. If you can jump forward a slide, I'll look at the domestic figures. So Germany eclipsed us last year. They had huge growth to take second place. The UK have been second place behind the US for some time. And we actually saw the UK growth at 227% year-on-year growth. Now, look, I want to buy some shares in this. The healthcare sector in the UK was well over 400% year-on-year growth. So this is a major concern. Ryuk, for your information, was still the the biggest family of ransomware attacks for the third year running. And you think, well, if we know about it, how can it be the third year running leader? And that's because small variants, small new changes to these known families of ransomware and other threat methodologies change everything, and typical signature-based approaches and sandboxing approaches cannot detect them. So it's important to have systems that can really do zero-hour threat detection. It's also worth saying the NCSC and us say don't pay ransomware. We're seeing a large increase in double and now worryingly triple extortion techniques where you'll have to pay 3 times to get your data, and even then it might be sent out into the wild. So a real concern around ransomware. We've got different systems for application, for endpoint, and for on-prem. If you can move forward a slide, please. So this, I just got off our CEO last week when he was over, and we had meetings with the NCSC and other critical government bodies. From January to May this year, on top of the growth last year, we've already seen 44% growth in ransomware in Europe and the UK this year. So shocking figures. If you could move forward a slide, please. This is an important one. So many SLTs tell you patch management is high up on the agenda, as it should be. But in this example, Log4j, Apache had a several-week window of exposure. Across our global network, we saw 2.7 million attempts to breach this vulnerability in a several-week window. Those are crazy figures. And this problem, due to legacy systems, will be ongoing for years. But in this window, Apache released 4 patches themselves to address this, which didn't address it in its entirety. So it's so important you have automated defenses that can protect against these vulnerabilities and not rely on reactive efforts like patch management. Go forward a slide, please. So a quick one on how we actually deliver this. Bit of a confusing slide, but right in the middle there, you see Capture Labs with a circle. That is where all of our intellectual property sits within the cloud. We've actually broken off a piece of this and deployed it onto an appliance that we can put within air-gapped, highly sensitive network environments. So please come to me outside of this call if you want to discuss that. It's a use case defined for the federal government and defence out in the US, and we've brought it into the UK now. But ultimately on the left there, you'll see that 99% of the 5.4 billion pieces of malware we saw last year were automatically protected by our systems, based on our AV, based on our AI and our intelligent coding. The 1% on the right that comes over into our sandboxing environment is where you really get to stand the difference and an enhanced protection. So Capture ATP is a multi-engine sandboxing environment in the cloud. So files come into you. If we're concerned, we send them up into the cloud. We spin it and emulate it and see if it's got any content to be concerned with. However, hackers know about sandboxing environments. There are easy ways around them and more complex ways like side channel attacks. Easiest things in cloud infrastructure, there's always a glass ceiling. So there's limited file sizes. Hackers are stalling malware actually executing so they don't get picked up. So on the right, you'll see RTDMI. This is our key differentiator. Patent approved in February 2020. It's been under development for several years. Real-time deep memory inspection sees us sit in memory where malware has to execute. And we see things at an artifact level. This is a game changer for us. And we deploy this architecture across all of our solutions: email protection, application protection, cloud, east-west traffic within cloud, infrastructure, endpoint, remote access. All of our solutions leverage this. If you could go forward a slide. So the critical thing for us is obviously effectiveness. Now, it's easy to turn the dial up on effectiveness and capture all of this stuff, but then that creates false positives. Here you'll see actual evidence. ICSA Labs took our underlying platform that I've just talked you through. That was going back 18 months, and they started a quarter review. We've now had 5 quarters with a completely perfect score. I've been in this industry 21 years and I've never seen this for 2 quarters, let alone 5. Several thousand tests. We detected every little known or unknown piece of malware with 0 false positives. Now, as I said, my CEO was over last week. He let slip to me that we've had a 6th quarter with 100% detection accuracy, but 1 false positive. And we're pretty chuffed with that because it makes us look human. 1 false positive in a year and a half is something to be very proud of. And if you can go forward one more slide, it's worth saying that RTDMI, this one engine, which is the last hop in our chain, actually is growing quarter on quarter. That blue graph there, the columns, show quarter by quarter this year, it's additional value it's adding to us, with over 1,600 now per day blocks of new or little known variants. And you've got to understand that every 24 or 48 hours, all of these findings go into our normal engines. So this growth of curve is on top of us adopting the previous week and quarters findings. So it's a very, very powerful system that can be deployed at your weakest point. And how we consult is we understand there are large scale investments and enterprise agreements with the likes of Microsoft, Amazon, Google. We take that on board. We're not trying to rip and replace at all. We're looking to consult, understand where the main risks are for any given organization. We currently work with 3 ICBs rolling out a mass of easily centrally managed small form factor appliances and Wi-Fi access points across all of their GP surgeries and remote locations. So these are examples of where we can deploy this kind of technology. If you can go forward a slide, please. So what should you be doing? Try to keep this very high level, increase user awareness. It's still a human behavioral problem, cybersecurity. You've got maliciousness and you've got accidental behavior as well. So that's internal and external. Endpoint protection, is your current deployment doing enough? Are you able to do threat hunting? Are you able to roll back? As I said, ransomware can start spinning up encrypted files even if we see it. So rollback on the endpoint is critical. Third-party validation. We've seen major NHS breaches. You can Google yourself where third parties have released data. We need to validate how secure third parties are, whether they're connecting to the network or on site doing work. And enhanced network segregation. This is critical to limit the damage and recovery that can be in place. Example in hand, HSE in Ireland. And ensure you've got an up-to-date breach mitigation plan. This isn't just to have one in place. Run it, test it, make sure your operational teams know what to do. Make sure you've got the syncs into your PR, your HR, legal teams, everything. This isn't just a cyber problem. So build it out, run it, test it, have third parties like us review it, and ultimately shift towards a zero trust and proactive approach to security. This is not ring fence, castle and moat. This is never trust a user, never trust a device, and never trust data. So more, you know, as we push on with this digital transformation, we need to look at ways that we can posture check users. We can do that no matter who they are or where they are, especially with how much remote access there is driven by the pandemic. So look, it's really hard to cram our entire story into 15 minutes. I really hope that's been a taster of what we can do and what's going on in the market. We've got a much bigger report, and I can spin up an hour session with anyone should you want to reach out at jmusk@sonicwall.com. So that's jmusk@sonicwall.com. Helen, that's it from me. I'm here and available for any questions. I think people are probably ready for lunch about now.
Oh, that's right. We haven't got a Q&A session with you, James, but it'd be nice to do one in the future. Cybersecurity is such an important subject, and I think from SONICWALL you managed to do a wonderful 15-minute presentation. And my apologies again that I hadn't actually put my notes in about what you were speaking about. So it was as much of a surprise to me as it was the audience, but it was very engaging. So thank you very much indeed. I'd also like to take this opportunity to thank our audience for joining us so far. I really hope that you're enjoying the discussions. We've had 3 panel discussions this morning, and do make sure that you take advantage of what the platform has to offer all the time, scoring points with our gamification tool. Those, just as a reminder, in 1st, 2nd and 3rd places will get Amazon vouchers or can donate in their name to their chosen charity. And by jumping into the meeting hub, you're building connections with delegates, not just for this event. You'll have the opportunity to connect with delegates who sign up for future events too. So let's meet back here at 2 o'clock after a well-deserved break, and let all the information from this morning's discussions soak in. I'll see you after lunch. Thank you.